Hello, my name is Dr. Alan Lumsden. I'm the medical director here at the Houston Methodist DeBakey Heart and Vascular Center. Welcome to this episode of DeBakey CV Live. We're really happy to host this along with the International Society of Endovascular Surgeons. Specialists, I should say. What we've opted to do is focus on the critical issues around the COVID pandemic. And one of the really hot topics actually is critical limb ischemia during the pandemic. And what we're going to be debating today is whether this is elective, urgent, or emergent. And we're going to examine the arguments and we're going to try and seek some solutions. So I'm really delighted to be joined with a co-moderator, one of the two co-moderators, Palma Shaw, who is the secretary for the ISEVS. So Palma, let me hand it over to you.
Thanks, Alan. It's great to be here today. Now that we're about 3 weeks into this fight, and we're moving from our mitigation phase into a containment phase, it's really great to have the experts here to weigh in on where we've been, where we are, and where we're going. What I'd like to initiate this discussion with is a little bit about the American College of Surgeons guidelines, which were drawn up and released to assist us as surgeons in trying to triage which patients need to be done now and which can be wait or can be postponed. Just to review, I know Dr. Lumsden has a slide to show this, but Tier 3 would be those patients that we should not postpone. They found it acceptable to intervene upon acute limb ischemic patients or those critical limb ischemic patients who have wet gangrene or ascending cellulitis. One other type of patient would be a patient with compartment syndrome who needs a fasciotomy. Tier 2 is postpone if possible, and those are patients with chronic limb ischemia with rest pain or tissue loss. Additionally, those patients who need thrombolysis, but it could be delayed, should also be considered to be postponed under these guidelines. And the third tier is postpone, which is those patients who have claudication who require peripheral angiography or intervention or bypass for that problem. So I would just like to introduce our specialists here today. We are honored to have Dr. Michael Lichtenberg, Chief Physician of the Department of Angiology and Pelvic Vein Obstruction Center at Haus Sauerland Hospital in Arnsberg, Germany. Dr. John Munbach of the Advanced Interventional and Vascular Services, Director of the Interventional Institute of the Holy Name Medical Center. Dr. Andrew Klein of Interventional Cardiology, Piedmont Healthcare. And finally, Dr. Peter Schneider, our co-moderator, Professor of Surgery at Division of Vascular and Endovascular Surgery at the University of California, San Francisco, will initiate this discussion.
Well, thanks, Palma. That was extremely helpful. And, these American College of Surgeons guidelines, as well as, multiple other organizations and institutions have kind of weighed in on this. And almost every hospital in the country, maybe every single one, has kind of come with some kind of internal working policy, what you can do and what you can't do. And it just strikes me that it really depends on where you're located, whether you're in an area where COVID is quite prevalent or whether you're in an area where COVID is not that prevalent. And so people have kind of found their own workarounds, if you will. And so, with that as a little bit of a preamble, I'm kind of interested actually in what's happening in Germany, because in Germany, at least here in the States, we're hearing that in Germany, things are under pretty good control, that the mortality rate is pretty low, that various activities were put into place in order to get at control, try to control it early. And so, Michael, what are you doing for your critical limb? Are you trying to triage? Are you doing everybody? Where do you stand on that?
Yeah, Peter, thank you very much. In Germany, we have faced that problem already for a couple of weeks now, and we had the possibility to learn from other countries, especially like Italy, our friends in Italy who suffered so much, and also from France and Spain. And so what we learned from them is to protect, to prevent, to decrease the workload and increase definitely all the things behind staff, technicians, and so on. So we are now in the plateau phase, coming out out of the dark now, and we have now around 2,500 deaths here in Germany. And so what we did from the beginning on, we did perform a triage, as you said. We stopped immediately elective procedures. We only schedule patients for critical limb ischemia, and we can discuss this, of course, in more detail later on, what that is. But fortunately, we are now coming back a little bit to normal, as the amount of patients is decreasing slowly now. So we are still already now in that phase that we can reschedule also claudicants. But triage, yes, this was what we started in the first weeks, and I think that is important for everyone. The triage is definitely important to invest in the resources to increase ICU beds. I think these are the most important steps, and that we learned definitely from Italy, because they struggled with that point, and we learned check your resources first and stop elective cases.
Yeah, I know, John Runback, you're really right in the, at least the US-based epicenter, just in your proximity to New York City, or really in the New York metropolitan area, I believe. Is that correct?
Yeah, we have 3 hospitals in New Jersey, an office-based lab in New York, and 1 in New Jersey. So, things are really still out of control here. Obviously, the curve is flattened, but out of control.
And so how have you triaged your critical limb patients, or have you? Do you do all your critical limb, or do you try to look for those who can, quotes, wait? I don't even know what that means, because I never tried to make a critical limb patient wait before.
Right. Yeah, obviously it's a new paradigm. We're about 6 weeks in, and I think we probably have another 4 to 6 weeks to go. I mean, our main hospital is 400-bed hospital. It's basically now a 250-bed ICU. And I really should give credit to the administration here and everybody for what they've done. It's actually engineering genius, what they've created here for all these COVID patients, with about 65 or 70 patients on vents. And we're the line service. So on top of everything else, we are part of the resources being utilized to put all the accesses in these patients. That being said, as you know, we have a very active critical limb ischemia program, both in the outpatient lab and in the hospital. And I think the paradigm's a little bit different. So in the hospital, we pretty much have shut down most PAD work. I mean, there are some patients who, for insurance reasons, can only come to the hospital, who have severe ischemic rest pain, or progressive ulceration and gangrene, and those we're doing. It's very, carefully planned sort of thing. And there are 2 considerations, for that. One is we really don't want to use up any personal protective equipment. Because even though this hospital's been very good at procuring those things, we're concerned about maintaining that. And the other thing is that we have to be very, very careful that no patient gets admitted. We really have no place to admit them. Obviously, we needed to, we could, but all the ICUs are filled with, COVID patients. We don't want to end up with somebody who's going to need lytic therapy per se. It would be very problematic here to do that. So when we do those patients, we actually change our strategy a little bit, and that we kind of do, safe interventions, very, very cautious, not to do anything too extreme. We're generally much more aggressive than this. We just want to get some flow back as much as we can and temporize these patients for later intervention. In the OBS, it's a little bit different. We put a lot of patients off, and now a month has passed. And so it's actually picking up. We're there twice a week, and I have 3 days each of the next 2 days, and each patients each of the next 2 days. And those really can't wait. And to give you a sense of how important this is, we had 2 patients who we delayed therapy on. One who just wouldn't come in because they were worried about COVID, and one who we were delaying. Both of them developed gas gangrene and had major amputation. So, you got to be very careful. Obviously, we tend to treat the most complex patients with extensive, disease. You really have to, one way or another, maintain contact with those patients. So what we've been doing is weekly phone calls, telemedicine or phone calls, just to triage them and make sure that we're not losing anybody. And that's been our strategy in the OBS, but we are kind of back in business.
So Peter, if I could jump in, Peter, because there's an opportunity two things we're going to do. One is we're going to pose a series of questions to the audience. It will address some of the issues that John has just raised. And secondly, a little bit later, we'll be able to take text questions in from the audience. So if we can run that banner again about how people can actually respond to this. And so in order to respond to the multiple choice questions, you've got to actually log on to the website. It's pollev.com/DeBakey. If we do that first, then we'll use the text messages a little bit later on. So let me give it back to you while we're going to leave that up for a minute or two, Peter, and if you can continue the conversation.
And Alan, could you just repeat the...
So it's being streamed out at the moment. It's actually, people can see it on the screens. It's pollev.com/DeBakey, DEBAKEY.
Okay, and can people go on that now, or should they wait?
They can go on that right now, and then when you next have a little break, I'll run through a series of 9 questions. One of them relates specifically to what John just raised, and that is, how on earth do you follow the patients when you can't bring them in the hospital and you've not done an intervention on them to try and avoid what John just talked about? I mean, to me, it seems like the drive-in principle should be, don't turn a semi-urgent thing into an emergency. And the question is, what's the strategy to try and prevent that from happening?
Yeah. No, these are really good points. I mean, maybe we could just touch on that for a few minutes. I mean, I myself had a little bit of opportunity to do telemedicine in my previous practice in Hawaii. Sometimes I'd be treating patients on different islands. Sometimes they would get a procedure done and go home the same day to, say, Maui or Kona or Lanai or somewhere like that. And so, and I got to say, I found telemedicine uniquely unsatisfying when a patient was actually having a problem. So, for example, if someone needed encouragement, or they needed to know their duplex or CT scan results, or they needed to inform me that they were all healed up and feeling fine, telemedicine was wonderful. The patient didn't spend the whole day to come for their 15 minutes of contact. But when a patient's really having a problem, I found it very difficult to triage. Obviously, the conversation is better than no conversation at all, but it's not the same as laying eyes and in the presence of someone and understanding whether they're in extremis or in trouble or not. So I don't know, has anybody else had any? Palma, what are you guys doing now in your practice to keep track of all these people?
At this time, all our elective cases have been halted, so I have at least 20 patients who really should have already been operated on. And I think I've spoken to every single patient personally. I put it into Epic, documented the reasons for delay and that we've spoken, their contact information. And I agree, it's a good idea to check in with them because they don't know when this is going to end and their situation may change. Yeah.
And Drew, what are you guys doing to keep track of your folks?
So we're doing the same thing, Peter, which is essentially I'm tracking my own folks and then calling them, trying to use telemedicine when it's possible. But like you, I find it pretty hard to, unless they have a webcam and they're savvy with it, to be able to show the wound and see how things are, really asking them to monitor their temperature and see if they're getting any cellulitis. It's just very challenging, especially as you know, most of our patients are older. Some of them may not be savvy. It's one today, while I was trying to do telemedicine, said cell phone. I don't even know what that is. And so it becomes a little bit of a challenge. We're really taking on a case-by-case basis and really trying to only bring those people in that we feel are really at high risk for progression.
So so let me just ask the group here. I know we're going to get to some specific case scenarios, but let me just ask the group here, who would you feel most comfortable to wait on? So, and let me add a little more flavor. When I think of like a true Rutherford 4, that is the patient can't sleep at night. I'm not talking they wake up once a week or once every month with a sore foot. I'm talking about they can't sleep. They've got, they're in the recliner or they're on narcotics. They're, a true Rutherford 4 to me, even though it's without tissue loss, might be the most urgent because you can prevent them from going to tissue loss. But others might come along and say, wait a second, no tissue loss. What are you doing? What do you guys have an opinion on something like that?
So I would say a patient with Rutherford 4 rest pain at night is, in my eyes, a patient with critical limb ischemia, and we treated these patients also during the last weeks. We scheduled these patients and tried to put them on the wards as short as possible, and try to do the intervention and send them home as soon as possible. But as you said, Peter, they're close to tissue loss. And we saw, unfortunately, a lot of patients now who came too late. We see a lot of CLI patients now coming who have now suffering for a couple of weeks, and now they come with highly infected CLI problems. And we have the fear in Germany, and I can definitely say this as a president of the German Oncology Society, we are in the fear of facing a second crisis after that COVID crisis in terms of these CLI wave, which might come during the next weeks.
You know, Peter, I think there may be three groups of patients here. So one is established patients who have the wherewithal to communicate effectively with you. Mm-hmm. We have a lot of those, so we can ask them how they're doing. Is the pain better? Is the pain worse? Is the foot redder? Is the redness progressing? Are the wounds improving or not? Those are pretty good. Those are patients you can really just kind of follow and track and intervene electively. The other ones that Drew talks about, which is probably 60% of the patients, they're old, they're sick, they really can't communicate effectively by telemedicine or even by the phone. And we assess as best as we can, but any sign of clinical worsening, if they're really complaining of pain, we try to get them in. And the third are the new patients who, are seen by their primary care, or we get referrals from other vascular surgeons, wound care centers, or podiatrists, who I just feel you need to see them. You need to make that assessment. The big problem is that most of the vascular labs are closed. So that's sort of a separate thing. We've been trying to bring them into the OBS, where we have a vascular lab. The hospital can't do it. They're doing DVT studies on COVID patients. So we've been trying to bring all those new patients in, but at least now it's probably half the volume that we need to see on a kind of semi-urgent basis, at least to make the assessment. Once we see them, obviously, we can triage appropriately.
So, John, let me ask you a question, because one of the hot button issues in the SVS town hall that we did was the role of the OBS. And you got two schools of thought. One is, are you crazy? You're in New York, you're using up all these PPEs, we hear there's a shortage. And the other school of thought is, well, you're really unburdening the hospitals. That's the place that these should be being done. They shouldn't be being done in the big hospitals. We should be pushing these patients to an outpatient lab. So how do you reconcile those two positions?
Yeah, I mean, look, we need to be judicious in what we do, but the hospital doesn't want the patients now. So, even when the hospital in the past has said, look, we want you to treat patients as much as possible in the hospital, they're now saying, can you evaluate them outside? So I think that it's somewhere in the middle, probably, Alan. I mean, the PPE utilization in the OBS is not that bad, and we procured separate PPE through private sources, so obviously it could have been used elsewhere. But we're very judicious how we use it. The utilization by our staff of 5 is not that great. We're not going through thousands of masks. So we've been fairly liberal about seeing these patients. I mean, what price is PPE for limb loss, right? And, unfortunately, given our experience of 2 patients who lost their limbs, we're just leaning towards seeing them early and making that assessment.
Mm-hmm. Very good.
Do you think, Michael, do you think some of those patients that you saw that delayed, did they delay because they were afraid to come into the hospital?
Yeah, absolutely. They said, we are afraid of COVID. We don't want to get in touch with that. We are the high-risk patients, so we don't want to go. So telemedicine is an option here, of course, just to have a look. Do you need to come urgently to the hospital or not? I think this is definitely helpful, But we saw, unfortunately, some really frustrating cases now who just waited 2 weeks, 3 weeks, and they had to come for an amputation.
And John, do you think the risk of contracting COVID for some of these older folks is less in the OBL than it would be in the hospital? I would guess that it would be, but I don't know. What do you think?
I don't know. I mean, look, we work very closely with the hospital. Like I said, they've been fabulous. And, the pathway from entrance to the hospital up to our what's left of our suites is a very safe pathway, and it's been protected. So they're probably safe. It's more the perception in their mind. They don't want to come to the hospital. It's been in the news for COVID. The OBL is very safe. All patients are screened. Nobody with fever is allowed in there. Everybody gets double masked before they come into any of the procedure or evaluation areas. All the staff is double masked the whole time. So that's been a very, very safe environment.
So
anybody
Peter,
who has slightest illness is not allowed in. So.
Peter, one of the text questions that's already come in is, and it'd be great to hear from Michael and from the US-based physicians, are you testing CLI patients for COVID antibodies prior to urgent endovascular procedures? Well, let's say COVID antigen and antibody would be nice. Michael, what are you doing? Now that you're in the restarting phase, are you screening all the patients before they come in?
Only if they have symptoms. If they have symptoms, cough, fever, or whatever, sore throat, then they were tested. We're doing a lot of tests in Germany. Around 500,000 tests are done per week. So I think this is one of the major things definitely which need to be done. Test. But we are doing in our hospital just patients who are symptomatic.
So I'm a little surprised by that, actually. I mean, I was imagined that as we ramped back up, you were going to have to be tested before you came into the hospital. So you haven't had any problems in relation to that? In other words, you operate on somebody and you find out that they're COVID positive.
So every patient with symptoms got bypassed from our hospital, from our vascular service. So if there are any smaller signs of some infections, these patients went to a special COVID unit and was checked there. And only if it's an emergency case, a real emergency case like acute limb ischemia, which need to be operated immediately, or highly symptomatic AAA, whatever, then went directly into the OR. But otherwise, they bypassed the normal hospital and bypassed into a specialized COVID unit just to rule out that there is infection, or if there is an infection, to treat them there in this special COVID unit.
So Peter, let's see if we can go to some of these multi-choice questions on the POLAV. So again, you got to be on polav.com/DeBakey in order to be able to answer these. So let's see if this works. So can we pull up these multiple choice questions here, please? And so the first question, if we get it, is what's your specialty? It'd be nice to know who's actually watching this webcast. Is it vascular surgery, cardiology, interventional radiology, vascular medicine, or other? So, well, we get it. So that it's up behind me. It doesn't have A, B, C, D on it. So can you see these?
I see the questions, but that's it.
All right, let's call vascular surgery A, cardiology B, interventional radiology C, vascular medicine D, and other E. Now let's see if we can vote on it. So on the panel, you've got interventional radiologists, cardiologists, and surgeons who are all debating on this. Maybe we'll keep talking for a minute until we get this working properly. We'll come back to that.
You'll show us when you have some.
Yeah, I'll tell you. Well, it should, but I'm not sure it's activated at the moment. We'll see.
Yeah,
we're working on it at our end.
Yeah, one thing we touched on right at the beginning, but we didn't go into much detail, is it just strikes me that it really makes a difference where you are and what's going on in your location. And what John is describing, his entire main hospital that he works out of is one big, basically, probably it's a COVID ICU, I'm going to guess, based on our discussions and what I've heard from others. And yet here, like in San Francisco, mostly the hospitals are sitting empty, honestly. It's been all cleared out for the other shoe to fall, but in general, it has not. I'm not saying I'm disappointed, mind you, but what we're mostly doing now by avoiding or trying to triage is we're mostly just following the rules rather than trying to, deal with a desperate situation like what they had in New York. And yet other places are in between. Like I've heard Atlanta's kind of, I guess it's a bit of a hot spot. How are things there?
So, Peter, it's actually interesting. We're starting to see a flattening of the curve in our hospital admissions, but the number of cases that we're seeing here in Georgia is now up over 13,000. That's nothing compared to New York. I think what's interesting here in Georgia more than anything else is we're still seeing a 3.5% mortality that gets replaced, it gets reported every day. So, in some ways, we're waiting for the other shoe to drop as well. We actually opened up we have a brand new tower, cardiovascular tower that we are building. We're opening it up. We actually opened it up early just in anticipation of COVID. So we have the capacity to take on 200 plus ICU beds. And so that's sitting there essentially waiting for the patients to come surge as of April 20th to 22nd is supposedly the time. I happen to be conveniently elected to the ICU during that week, so wish me luck. And I think it's in many ways just very depending. I'm on phone calls daily with my friends from New York, and what you're hearing up there is just a battlefield compared to what we're seeing here. And I think it's in some ways, if it's same thing with the myocardial infarction, a lot of people I think are sitting at home and are waiting for and trying to avoid coming in.
Yeah, interesting. And there is one really, really good thing about being a vascular surgeon, and that is that in the ICU, we would just be in the way mostly. But as a cardiologist, you actually could get drafted into service, for goodness sakes.
Yeah,
And many have actually.
Yeah,
And
actually, in New York, many of our ICUs up there are being being run by cardiologists, having to relearn the vents and everything else. And I already attend on our critical care service, so unfortunately, I'm kind of prime pickings to get chosen for a COVID unit if it's needed. So,
yeah,
getting my PPE all fitted up.
yeah. One of my sons is a hospitalist at a Bay Area hospital, and he's on a ventilator training, doing some ventilator training, to prepare for that eventuality. Yeah, it's kind of completely crazy. Palma, what's happening in your area?
Well, we're doing, like you were saying, a lot of waiting and anxiously concerned about the patients that are sitting home that do have critical ischemia and rest pain, and I'm not allowed to operate on them. And I don't feel like it's okay, but again, we don't know what else to do. We actually sent people, our nurses and our respiratory therapists, down to Stony Brook because we're a state university hospital for New York. So we've sent people down there. Some of our hospitals have gone there to man the Javits Center, and so we're helping in that respect. But as a vascular surgeon, we can't really help as much as we would like to help. And I think I'm very concerned that we have a population that may come 3 hours for care. We have a lot of rural populations that come down from as far up as Canada and as south as Ithaca, New York. And I'm concerned about how they're going to present very late. And, I think we're going to lose some lives while we're just waiting.
Yeah, yeah. And that, I guess, Stony Brook's in what, Suffolk County, and that's kind of a hot spot area also, right?
Yeah, it's really bad. My colleagues down there, yes.
Yeah. And then, this whole issue about, us needing to respond to local circumstances is so interesting because I don't know, like, for example, and maybe I said too strongly that the hospital's sitting empty. I mean, we have COVID patients, but it's not, it's not fully subscribed. We have excess capacity purposely, waiting to see what's going to happen next. And I guess the question is, I mean, this is really a national and in the US, but also international question for every country. And it sounds like Germany, you're already dealing with it. How do you get going again? What are the things that have to happen to prove to you that it's okay that these top priority patients no longer you don't need to scrutinize a triaging system and you can bring in these critical limb patients? So back to you, Michael. What was there some turning point or some evidence base or something that made it seem like it was reasonable to try to get back toward? I heard you say earlier in the hour that you were now treating some claudicators again. Is that right?
Yeah, but this does not count for general, I would say. It definitely, as you already said, depends on the individual situation of every hospital, of every unit, of every university clinic. So if you have capabilities, if you have a free ICU, if you have beds, if you have staff available, who's not sick at home, then yes, I don't see a problem to move forward now as the curve flattened. Otherwise, I must say we will face a very huge amount of patients in May, June, then coming as a wave. We can't cope actually. So every, I think, unit, hospital, university clinic has to answer it on its own capabilities. Are we able to come back to a little bit normality? But I think it's not possible to say this in general.
Yeah, yeah. And Drew, what do you think? You said you have all this capacity, and I guess when you say that you think it's going to peak and you gave a date, is that based on the IHME projection of the pandemic, or how do you anticipate when you think things will peak in terms of resource utilization and mortality?
Yeah, that's based on our kind of estimates from what what we're being told day to day. That's not up to me per se. I think it's a challenge right now. We're really limiting in hospital staff. For instance, we only have one team in house for lab cases, and it doesn't matter if it's a cardiac case or an urgent vascular case. I think it's one team and that's it. And we're really trying to limit the exposure of the staff more than anything else. And most of them are home. Some have been redeployed to other units in the hospital, which raises a big issue of if they're being redeployed to COVID units, is that a good idea? But at the same respect, you're trying to balancing this idea of exposure versus continuing to do your job and everything else. There's a lot of challenges that go with this, and our administration's done a pretty good job at being able to balance all this. And I think it's, for us personally, I think it's really about trying to do what's best and that time is as data comes in each day, you just have to kind of meet. And we have a whole command center that meets daily every day and goes through perhaps changes that need to happen. So very dynamic situation.
Yeah, interesting. I see Alan starting to put up some data for us. Alan, can you hear us?
Yeah, I'm here. So
Oh,
let's do that again, because I'm not sure that's totally representative. We switched out computers here. So I'd be surprised if nobody's a vascular surgeon. It means nobody on the panel voted. Let's come back to that one and go on to the next one. And the question is, where do you primarily perform lower extremity interventions? In the hospital A, outpatient lab B, some sort of ambulatory surgery center, or other? And it takes a few minutes really for this to be tabulated.
yeah, yeah.
And I think that many of us perform, in both places, right? It's not just one or the other. So.
Yeah, let's call it primarily. Where do you do most of your cases? So for you, John, I mean, are you evenly split between the hospital and the outpatient lab?
Essentially, yes.
Okay. So yeah, we don't do anything in a pure outpatient lab. We probably should be. So the overwhelming majority of people in the hospital. Next question. At the present time, I'm performing procedures for critical limb ischemia only, claudication and critical limb ischemia. All right, nobody's going to admit to doing claudicants in the middle of this. That's probably good. The pandemic has changed the type of procedures I would offer a patient with critical limb ischemia. I think you've kind of already alluded to this a little bit, and maybe we can discuss this a little bit later. So, Peter, patient comes in, and they've got an ischemic great toe, and they've got long segment SFA occlusion, POPs occluded, and there's single vessel runoff. Are you going to try and do anything from an endovascular standpoint?
Yeah, I think this is an interesting question because there's a little bit of a sliding scale here, in my opinion, that we want to try to get the patient through this with the least amount of resource utilization. I don't really want to do anything that's going to end up with that patient having to be in the hospital for many days. And so I might be tempted to try something that maybe has a lesser long-term patency, but is appropriate to the idea of doing something and getting the patient home. So I would say that if it's a complex bypass, I would like to put that off.
Okay.
And yet if I can put it off by doing something endo and sending the patient home, then I think I would agree with that approach. Although, obviously we're making it up as we go along. I don't know. Tell me, somebody else offer an opinion. Would you differ? What do you, Palma, what do you say? Do you try to avoid doing a bypass, or?
I think you're spot on, Peter. I mean, I think right now we're really in almost a war type environment, right? It's not how we want to do it. It's almost how we have to do it. My hospital will not allow me to do a distal bypass right now. And my colleagues have had to do above knee amputations on patients a couple weeks ago, on patients who really need an aortic bifemoral bypass. And in the end, the patient got an above knee amputation. It's not what we want.
But
it's
Palma,
what's really
Palma, let
happening.
me push you on that. I mean, who's going to tell you that you can't do a distal bypass for a threatened limb? I mean, really?
My administration, yeah. They will not
That's
allow me.
amazing. I mean, so I've done a distal bypass. So let me tell you, this is kind of how you get sucked into this a little bit. Patient came to the emergency room. Probably it was our primarily ischemic leg. It's a little bit confusing between ischemia and infection. And the resident saw the patient in consultation. The resident was afebrile, doing fine. Okay. Overnight, I went to see the patient the following morning, and overnight the patient spiked a fever. Now the patient was PUI, but the patient needed to go to surgery. And so we ended up taking the patient to the operating room. Did a couple of things, including basically, because we were worried the patient had necrotizing fasciitis. This patient is also immunosuppressed. So we opened the lower part of the leg. And then the next day the patient was confirmed COVID positive. So now we have open wounds that I've made in the foot and in the leg, which is now we're committed to going back into that room, almost on at least every other day basis to kind of check those wounds. Did I do the wrong thing? The second interesting issue that came out of this, Peter, was this is a dialysis access patient, failed kidney transplants. Anesthesia was using the trialysis catheter or a double lumen or whatever it was they had in for the dialysis. 2 days later, the patient is sick. They said, "Oh, we don't have enough access. We need another line." Well, we do have a line team, but the line team, because the patient's all occluded up top, now we'd made incisions in the groins and in the leg. They don't want to touch it. Now it's our problem to get access, and now we got to go back into the room for another reason. And so there are a whole bunch of logistics that you kind of get sucked into as you're starting to manage these patients.
Yeah, the logistics on this are a potential nightmare. No question about that. I mean, I think, and so what did you determine was the patient's lower extremity problem? Was it a combination of infection and ischemia, or was the fever
Be honest
always?
with you, I'm not entirely sure. All the cultures have come back negative. The patient had occluded iliac, complicated patient, and we actually just did a fem-fem crossover, thinking minimal surgery that we could actually do in this patient, and it was much better, including basically with the COVID. But it's the secondary problems of now having to manage open wounds that we've created that I don't think we had kind of thought through. We realized we were going to have to do it, but that's pretty difficult. And it's a little bit about sending the patient home and trying to see their wounds. We've tried to look at their wounds because we have virtual ICU, but it's really, you can't really do it. You certainly can't change the dressing. Somebody's got to do it, and it might as well be us.
Yeah.
Okay,
what's
so
the situation like in Houston, Alan? Is it a very saturated area from a standpoint of the pandemic, or not so bad?
No, I mean, we've got the largest number of COVID patients in the city. We've probably got about 140, 150 at the moment. We have at least 2 ICUs, opening up a 3rd ICU that are full. But it's not like we're overwhelmed by it. We certainly have the capacity to handle this. And most of these patients are doing fairly well, actually. We've had multiple patients on ECMO, and a lot of them have actually come off ECMO. which is, we always worry about the vascular complications, even though it's VV ECMO that most of these patients are getting. So, but I think what's happening, Peter, is that we've had enough sick patients in the hospital. You know what happens? They start getting complications. We've seen retroperitoneal hematomas, we've seen DVTs and pulmonary emboli, we've had ischemic legs, and so, sick people get complications, and that's usually where we end up getting involved with them.
Yeah.
So let's go on
Peter,
through this.
I just want to make one comment about, when do we sort of get the ball rolling again? And I think a big part of that is when we have adequate personal protective equipment, because, as you know, I had COVID from a patient and recovered, and we've had other staff members who have. So once we have adequate personal protective equipment that we can, really cover our patients effectively and cover ourselves so we don't get sick, then I think that, we can be more liberal bringing these patients, in. Obviously, logistic factors are important, but I just want to say that I think that's, if we had adequate protective equipment for patients and us, then obviously we can, sort of get the ball rolling sooner.
So John, on SVS Connect over the weekend, which is kind of a discussion group, there are at least 2 vascular surgeons, actually at least 3 that I know of in New York who've contracted COVID. Now, mercifully, they're all doing fine. I mean, do you know of your interventional radiology colleagues?
Besides me, I don't know anyone else.
Yeah. All right, I've changed the location of where I practice critical limb interventions. True, 40%. Most people are still working, in their original institutions. But to your point, John, I'm not sure we shouldn't be looking a little bit more at the OBLs. Peter, do you have access to that in San Francisco?
No, we don't. If we did, I think if I did, I would use it though. And I think honestly, the COVID thing notwithstanding, I think most lower extremity endovascular interventions are going to be pushed out of the hospital and out of the acute care setting. I think that's at least, and I don't, this doesn't apply to Germany, but in the States we have this thing called CMS, and they pay the bills, and for whatever reason they've decided they want these procedures out of the hospital, and then that's where all the incentives are. And it makes sense to have an added incentive to me to have them at the hospital right now to lower the risk to the patient and also to lower the likelihood of taking up precious resources, that kind of thing. I don't know anybody else, and it sounds like, John, you're the one with the most active practice. How has that evolved pre-COVID in terms of your ability to treat critical limb outside the hospital?
Yeah, I mean, ours is a critical limb ischemia practice. 80% of what we treat is CLI. We've had to change what we do because we've encountered in the OBL sort of what we're now encountering in the hospital, that you don't want to have someone admitted to the hospital. So we've changed some of our strategies for intervention to try to avoid acute complications. We're much more liberal with anticoagulations. We'll send patients home. I know they do a lot of this in Europe with low molecular weight heparin for some period of time to avoid acute thrombotic complications. Obviously, we have the Voyager data now. But we're really migrating our practice out to the OBL. And truth is, there's very little we won't do. We'll do distal DVAs out there, complex pedal arch, multi-vessel reconstructions. And I think you're right. There are patients clearly who need to go to the hospital for a variety of reasons, mostly comorbidities. But as much as we can do in the OBL, we prefer.
So let me ask, so Michael, from when the COVID epidemic started in Germany to now, what's that time course? Are we looking at a month and a half?
Yeah, 6 weeks is a pretty good estimation. Yeah, so after 6 weeks, we reach now the plateau, and now it starts probably slowly decreasing. It's the same in Austria. Yeah, they are now below that plateau phase, and now they are decreasing and getting more and more back to normal.
And in terms of, as you say, getting back to normal, who now regulates what cases can be posted? So we're under, the governor has basically said in Texas, emergent cases only. Now therein lies basically a lot of wiggle room. But they also encouraged other physicians to turn in the physicians who are doing non-emergency cases. And so is there a statutory body in Germany that determines or gives you guidelines about which cases you can do?
No, there is no, the government can't dictate you which is an emergency case, which is not an emergency case. they give you some advices, they give you some support, but they definitely can't make a definition of it. They only say do not waste your resources. You have to take responsibility to increase ICU beds, check your staff, respect your staff. These are things we definitely look at, but there's no one who can really dictate us, don't treat claudicants or whatever. So this is really based on physician decisions together with the hospital administration.
So John, in the OBL, who regulates it? I mean, one of the concerns a lot of people have is abuse of it. Is all of a sudden, we move the cases to OBL and there's no limitation on what cases can be done. I mean, in your environment, who determines what cases can be done there?
Well, I mean, the governor has given a mandate that only urgent, emergent things should be done. So we followed that mandate. We, followed OEIS guidelines and other guidelines. So we have our own guidelines within the OBL about what we will and won't do, and of course about what we do. So, we're trying to be responsible and not just treating everybody. Like we said, there's a very vigorous screening process. For instance, we no longer let sales reps in. They're just not in. If they do need to monitor things, they do it remotely via Zoom or something like that. They're no longer involved. The rooms, the cleaning process between cases has changed. All the patients are covered, we're covered. So, you're right. I mean, we are sort of self-governing, following existing guidelines, but we're trying to be very, very adherent to that.
Have you had any patients who have to be admitted to the hospital as a result of a complication?
Well, we've been in this OBL about a year and a half. We've done close to 400 patients there. We've admitted 2 patients.
Okay. And none since this started?
None since this has started, thank goodness.
All right, so let's look at this. Most people think it's going to be 4 to 8 weeks, or let's say 4 to 12 weeks before we actually kind of get back to at least half of what we were doing beforehand. I think that's probably pretty reasonable. Anybody in the panel disagree?
No.
It's kind of in line with what you're saying, Michael. All right, now, John also touched on this, is that, we are heavily duplex dependent, and that's what we do a lot of the screening with. And so the question is, my use of duplex ultrasound testing is the same as pre-COVID, very selective, or emergent and urgent only? I can tell you that in our hospital, it's emergent ultrasound only, and all of that has to be screened by the medical director of our vascular lab. And so you got to have a pretty cogent argument of where you're going to get an ultrasound done. Andrew, what's happening at Piedmont?
Yeah, we're trying to do the exact same thing. We're more on a very selective, especially at the inpatient side. I think, for those of, as this is a hypercoagulable state. So for the COVID positive patients, we're really trying to avoid subjecting our vascular techs to anything. But for those patients, it's a little bit different because there's clearly, having recently been on a webinar with COVID and pulmonary embolism, there's a major issue that occurs with these patients with DVTs. As per the outpatient side, we're really, you need to make a strong argument. And that's the same thing actually with our cath labs. We're really trying to make it a 2 attending decision for our cardiac cases and say, do these patients really need to come down to the lab or do they not? And trying to limit exposure across the board.
Okay. Now the ultimate question, I have a partner staff member who has contracted COVID. I guess you can throw ourselves in that too. So in the SVS Town Hall, we kicked it off with one of my fellows who finished here last year, and he's up in Hartford, and he contracted COVID and had a pretty rough time, but fortunately he's a lot better. So that's kind of a shocking number. I'm not quite sure what the denominator is, but there are a lot of people who've got it.
It's considerably higher than the general public, so.
Yeah. All right, I think that's probably, last one. It was relating to what you brought up, John. So let's say you've got the patient with the gangrenous toe. You're not going to cut it off, Peter. Is that what you're telling me? Dry gangrene.
I think if you could revascularize and don't do any foot surgery that's going to keep them in the house, that to me would be the best.
Okay. Palmer? They got a big old nasty toe down there, and you've done sort of a limited revascularization. Do you just leave it?
No, well, fortunately, I work at a wound care center, and we are seeing patients selectively there. So I think it's a good bridge to collaborate with the wound care centers to try to keep the wounds basically stable. If they have dry gangrene and treat it with Aquacel Silver or other local products, maybe you can stall before you have to do anything, when otherwise you may already have done the toe amputation or some foot reconstruction.
See, I think John made a tremendous point, and it's really patient dependent. I mean, what you don't want is the patient who comes back in with the wet gangrene, and some patients you can depend upon are going to be very vigilant, other ones are not, and you kind of have to make that decision up front. It's interesting, Peter, that on another patient that we did do a distal revascularization on, now the patient was not COVID positive, but we didn't take the toes off. And I actually thought that was a mistake, that I probably, if I'm going to go to the trouble of doing surgery, at least on the patient, I think this is where the endovascular and the surgical approaches are a little bit disparate here. Endovascular approach, I'd probably leave the toe on. If I'm going to go to the trouble of doing an operation that I know the patient's going to end up in the hospital for the next 3 or 4 days, I probably should have gone ahead and done the amputation at the same time, so I don't commit the patient to coming back for a second time. So I do think the strategy of how you're going to manage these patients becomes very different.
It's a good point. It's also very interesting how all of these different factors, I already think of many of these things on sort of a sliding scale, whereas you're trying to make the treatment suit the disease process, and the disease process is so highly variable, as well as the various, the treatments that we have, especially revascularization treatments, real difference between an open surgery and an endovascular approach. And then you throw in, your geographic area and what's going on there, and what your hospital administration is saying, and what your partners are saying, and how much of a hot spot it is, and what your PPE availability. I mean, all these things, tremendous variability. And then you're trying to come with an answer individualized to each patient. So I think this time we're going to forgive you, Alan, for doing what you said was the wrong thing. We're going to let you off the hook this time about the toe surgery. But I totally get where you're going with that, and it's incredibly complex when you include all these variables that could go different directions, and then trying to come with a singular plan for each patient.
Okay, so let's go over to the text questions. So you can text questions in now to DeBakey, D-E-B-A-K-E-Y. You text DeBakey to 37607, and now's your chance. Send in a bunch of text questions, and we'll put the panelists on the spot here. They deserve it. They really deserve it.
Well, while we're waiting for questions, I'm interested to ask the entire panel what your experience has been. Drew already referred to it, this issue of the hypercoagulability. Obviously, this is something that happens in any patient population that's incredibly ill, but this seems to be more so than your standard critically ill patient population. I talked one day, I spoke with Gary Ansel, and he said at his hospital, they're doing substantially more pulmonary embolus interventions than they were doing before, and he thought it was COVID based. And so I'm wondering from the group, what has been your experience so far with specifically COVID-related vascular issues?
Well, we're definitely seeing a lot more DVT and PE. It's actually a problem for the techs in terms of sort of how often they follow these patients. Below knee, and not only that, they both clot and bleed. So it's a complex problem. Below knee DVT we're following. I think actually there's going to be explosion. I mean, I just did a PE right before this call, but there's going to be explosion of patients as we sort of stabilize. So we're going to now prevent with proximal DVT that we were just sort of observing, and they're going to need some sort of treatment. The PEs, tell you the truth, talking to my intensivist, there's a lot of PEs, and they're not sending them over as regularly as they would have before because of the logistics of getting them out of the ICU with the tents into our angio suites, which then need special preparation. So there are a lot of potential PEs, but I think because the logistics, as we talked about, they're probably not being treated with catheter-based therapy.
So Peter, if I can jump on what John was saying there, I think a couple things that we're really trying to work aggressively on an anticoagulation strategy. We're following the D-dimers every day, and once we're getting over a certain level, we're trying to really increase our low molecular weight heparin use as long as they're outside of renal failure in an effort to minimize staph and checking blood draws and everything else. So first thing is prevention for these patients. And like John's saying too, we have a pretty active PERT team here. We're really limiting any sort of intervention, if any, to the submassive pulmonary embolisms, maybe even giving lytics, just like we're doing for STEMIs in COVID patients if need be. So we're trying to really, again, the logistics are a big issue, also the exposure issue, and a lot of these patients are too sick to travel. And so I think the first thing is prevention of pulmonary embolism, and VTE is first and foremost, and that requires really aggressive strategy. There's clearly a high procoagulant state with these patients. And I agree with you, John. I think we're going to see a true explosion in this as patients become more, as they get out of the hospital. And there are some places in the US that are actually sending patients home with DOACs for a month afterwards based on some data to try to prevent those patients from coming back with the PE.
So
just
Peter,
to add to this is the issue of the filters too. I mean, we put some bedside IVC filters in with IVUS. Obviously, you have the Angel catheter, which I have some concerns about, but that's another issue too. I mean, how do you manage these patients who are bleeding, have DVT, and maybe need filtration? And that's also been challenging.
Yeah.
Okay, so let me tell about the case we had here, and that was a very young woman who had COVID, was diagnosed as having bilateral DVTs, and then developed a pulmonary embolism. So what do you do with her? I mean, she was decompensating pretty dramatically. And it kind of relates to question number one that we've got up here. We're going to talk about that in a minute, and that is, can we pop that one up? Yeah. Are we avoiding lysis? So what we do with that? What we do with somebody like that? PEs, bilateral DVTs, on anticoagulation is the key part to this scenario.
I think for us, we would consider lysis and be aggressive in maybe, and you can start. Many of our patients might even try a 10 milligram dose, push dose, and then 40 over 4 hours, kind of a reduced dose lytic.
So how are you going to? So you're going to deliver this? This is catheter-directed therapy you're talking about?
No, IV.
IV. Okay, so we gave her IV. Didn't make any difference. She didn't get any better.
If you're giving 50, then I would go then to 100.
No, we gave her 100. Unfortunately, we gave her 100. You're still on the hook here.
Yeah. So I think at this challenge, in terms of before, let's even back up. Before you're giving lytics, I think one of the options is what's happening from, and we'll use point of care ultrasound to look at the RV, try to understand a little more what's going on if it's clot and thrombus.
Severe right ventricular strain.
So for patients like this, we might even opt to put on ECMO first. And then have that discussion. I think once you have them support it and you have their RV support it and you have things more stabilized, then you can talk, you have some chance to breathe and then discuss with your PERT team. And I think it really does need to be a PERT team decision.
Okay.
Yeah, I would say obviously we're using IVC filtration if they have known DVT to prevent another recurrent PE. And that's relatively easy to do bedside. You can use the Angel catheter. But just like the catheter patient we had today, this is a patient.
So can I pick up on that, John?
Yeah.
Nothing's easy bedside in these patients. And so first, I can show you a picture is that, all the lines are outside the room. They're all crossing the floor. Every piece of equipment, first of all, you're inside a PAPR, you're wearing an N95, and then you got to lift all the equipment into the room. You got to lift it over all the lines, which normally are bedside. It's pretty hard to do things in the room. It's not real that easy.
I think you're right, Alan. Obviously, it depends upon where you are.
Yeah.
This hospital's done a great job. So we bring the IVUS in. It's actually not that hard, but it's going to depend upon, how things are set up and what your location is, of course.
Okay.
But with regard to the patients who have a decompensated PE, who clearly have right heart strain, they're making troponins, they may be having, desaturation. We've been actually doing more thrombectomy in those cases, trying to avoid lytic. And
okay.
I would agree. That's a good point. Mechanical thrombectomy would be a good option here. And to your point, ECMO is a very good supporting factor here. So we would combine here mechanical thrombectomy with ECMO probably here in such a respect. Yeah.
So we put ECOS catheters in, put an IVC filter, put ECOS catheters. The plan was running for 24 hours and see if it's any better. It's dramatically better, actually. But just the logistics of transporting these patients. Second thing that we hadn't anticipated is Now the ECOS machines need to go in the room, and none of the connections are long enough to come outside the room. So as soon as the patient got up there, all the alarms started going off. And so now you got to go back in the room in order to basically troubleshoot what's going on. So it's just an example of everything you do has consequences that you hadn't thought about. ECMO, that's a whole nother ball game in terms of monitoring patients who are on ECMO with COVID. Anyway, so let's talk about the lysis in the lower extremity for ischemia. Are you guys using, would you use lytics in a COVID positive patient?
No.
No?
No, I wouldn't do this. I would go for a mechanical thrombectomy or aspiration thrombectomy. No lytics in these kind of patients. And these patients are on risk for everything, for bleeding complications so much. I saw some of them at Vent who experienced so dramatic bleeding complications, I wouldn't go for lytic therapy.
All right. Anybody else want to chime in on that? Lytics? Lytics is a no. Huh? Okay, mechanical thrombectomy.
Lytics is last resort, yep.
Yeah, last resort. Okay, here's another question. I think we should discuss strategies of coming out of the pandemic, as patients are absolutely petrified of coming to any medical institution. And the reference is Tim Henry's patients. STEMI's 44% down. Patients stay at home with chest pain. So how are we going to persuade patients that the hospitals are safe on the back end of this pandemic to come in? I mean, again, thoughts from Germany? I mean, are patients concerned about coming to see you?
Oh yeah, absolutely. We just got some numbers that 30 to 35% less admission because of a heart attack or strokes were seen during the last weeks. So this is a dramatic number, 30 to 35%. So that means the patients stay at home because of this irrational opinion. Once I got in the hospital, I got contact with COVID and then I'm dead. And this is something I think we need to respect and definitely talk to the patients, to convince them. If you are going to hospital, if you're admitted to hospital, doesn't mean that you are automatically have contact with COVID. Take care of your problems, of your heart attack, of your stroke. So I think we need to raise media campaigns for patients to clearly show them what is the right way really in these situations where they might have a heart attack or stroke.
And Michael, you also said you had a couple of patients that stayed home with ischemic limbs and end up with amputation. I got to say, if someone just goes on the television or on the computer and tries to get an assessment of whether or not it's safe, as a non-medical person, I would think you would be absolutely horrified and with concern, with worry, and I think what you said is right. We have to treat the whole patient. So if a patient is so worried that they stay home with a threatening condition, they're worried that there's a worse fate waiting for them, well, then we have to do our job, I think, and really talk to these patients. And maybe even as this thing starts to alleviate in various places, we need to be really specific about what we're doing to protect them as they come into the medical care system. And John already mentioned this about, typically the patients now in my hospital all have masks. And that's to protect us, but we all have masks too, and that's to protect them. And so just elucidating how the different things that we're doing to protect them, I think, is going to become front and center as soon as the acute crisis starts to ameliorate a little bit.
Yeah. So we just initiated a campaign in Germany called "Don't Let the Virus Be Responsible for Your Amputation." This is a way where we try to really convince patients to come to the hospital once they had a critical state, whatever. And physicians are standing in front with mask and say, "Don't let the virus be responsible." So we do all our best to protect you, but please come to the hospital.
So how are you pushing that out, Michael? I mean, how do you communicate that? Because that's a very important point.
Yeah, we just started as using newspapers, all kind of Twitter, Facebooks, and so on, social media to really, convince them. Yeah, we do our best to protect these patients, to protect you once you're in the hospital, that you are not affected by COVID. But please take your sickness, your illness serious.
Can I ask,
Otherwise-
have you seen a situation, so I just started and mentioned a couple of minutes ago that we have more COVID patients than anybody else in Houston. Well, that may not be perceived as a good thing as we start reopening and patients are looking for a place to go to. Have you seen movement between institutions based upon that perception?
Oh yeah. The thing is, we have
It's
in
not
Germany.
the answer I wanted to hear.
Yeah, we have in Germany small hospitals who only exist of one building. Yeah, once they are affected by COVID, they have a total shutdown. They have no chance to treat any longer patients. Yeah, then these hospitals are bypassed, of course, by patients, by referral ways. So I think it is important to organize any kind of information system, how the individual hospital has a problem with COVID or not. How many patients are in the hospital? How many patients are affected with COVID? What is done by the individual hospital to protect? Unfortunately, we don't have such a system. Other countries in Europe, they do have this information. You can log on this system and you get a lot of information about the individual hospital.
And Alan, don't hesitate to send us your good cases.
I'm sorry, say that one more time, Peter.
I say don't hesitate to send us your good cases.
Yeah, a long way to San Francisco or Hawaii. They might go to Hawaii. I'm not sure about San Francisco. But San Francisco doesn't seem to be that bad in terms of the amount of COVID that's going on at the moment, Peter.
No, it doesn't. And I got to say, it really defies explanation. I mean, I think eventually we'll understand it better, but there is just such a wide, sort of a wide open exchange between China and the West Coast of the U.S. I just can't imagine that we didn't have it here early on. So why didn't it grow with the same ferocity that it did in New York? It doesn't make a lot of sense. Santa Clara County, which is just south of San Francisco, was opened up almost with the same level of cases as Seattle was at the same time. If you recall that, Seattle was one of the first places in the U.S. where it was clinically became very apparent, and I think Santa Clara County immediately put, they did a very early shelter-in-place order in the 7 counties around the Bay Area. I think that made a difference. They had an early shelter-in-place order, but it makes me wonder, there's so much communication between China and Silicon Valley, for example. It makes me wonder why it's not a big, obviously we've made big changes, but we've mostly made them in preparation for something we don't know if it's coming or not. It's not like New York, where they turn the ORs and every other available space into an ICU bed. So is there a herd immunity on the West Coast that we don't have in other places? But it defies explanation. I mean, we should be in much worse shape than we are, even notwithstanding the early shelter-in-place order, because that won't solve your whole problem, in my opinion.
So Peter, well, I got you. Let me ask you one specific surgical question. That is PTFE versus vein graft. You got to do a bypass. It's going down to the baloney pop or a tibial. You can do it a lot quicker with probably a lot less blood loss by putting a piece of PTFE in there versus pulling the vein out. Would it make any difference? Does that affect your decision making?
I don't think it would for me. I don't think it would. I would probably do an above knee, but I think anywhere distal to that, we know that prosthetic's not as good. And I don't know, by adding a few days of hospital time, is that really going to change things? Probably not. So I would feel compelled to to do what I normally would do if I have to do an operation. I already mentioned maybe I'd stretch the indications for endo rather than go to an operation. But if I do an operation, I don't want it to be one that, that's compromised.
Would you
Just
take
a
arm
thought.
vein?
Oh, you're being kind of persnickety now. I don't know about arm vein. Yes, I probably would. But obviously, you could keep escalating this operation until I say uncle.
Yeah.
But clearly there are some pretty complicated things that we could do, and we already said we want to avoid doing anything more complicated than we have to. So I don't have a great answer for you, but I think I would, if I'm going to do something open, I should do something that I don't have to revise anytime soon. I should do the longest lasting open operation.
Okay. So the question for John is, have you had any COVID positive patients end up coming through your OBL? And what did you do? And what did you do with it? Yeah.
Yeah, not that we're aware. We've had COVID positive patients at the hospital who are currently up in the ICU, who I believe I acquired it from. But so far, our screening has worked in the OBL. We do follow these patients afterwards. None of them have gotten sick so far. It's a good number. So let's keep our fingers crossed.
You want to tell us about your experience, if you feel up to it?
Well, I don't get COVID. I was sick for about 5 days and really sick, 102 fever and diarrhea and terrible myalgias, loss of smell, loss of taste. But worst of all was horrible cough. Didn't sleep for 5 nights. To spend the night in the shower, sitting on the floor as long as I had hot water, just trying to get steam. So I would recommend against it. But I've recovered. I've done the convalescent plasma now thing. So thank God I've come through it. But it's scary. Yeah? I mean, it's definitely something you don't want to experience.
So you know the designated line placement guy and the interventionist for the COVID patients?
Well, our whole team, the line placement team, even I've got some young guys with some young kids at home. And at first they were hesitant, we actually had some pushback from one of our docs. But, in the end, I think everybody stepped up. We all want to do our part here and help as much as we can. So.
Well, it's kind of interesting because everybody's got a vulnerability somewhere. You have young kids, pregnant wife, older. When you start taking out all of these different pieces, your team can be down to nothing at the end of the day.
Right. No, absolutely. And, there was a lot of, pushback also from the nurses and the techs originally, because we go in as a team. They said, no, now you're going to go in alone. And we just said, quite frankly, we don't work that way. We're just not comfortable doing that. And, at this point, that lasted maybe 2 weeks. At this point, everybody willingly goes in. Again, this hospital's done a spectacular job. We have adequate equipment. The processes are in place. And I think the philosophy has really changed, maybe because we've been overrun, that everybody wants to do whatever they can do to help. So,
you want to deal with this question? We've kind of already dealt with that a little bit, but are you treating proximal DVT with thrombolysis to prevent post-lipidic syndrome years later? I think that was a resounding no. Worry about that down the line. Non-limb threatening at this particular point in time.
Yeah. One thing, Alan, Peter, just to follow up on something that John said, I think most places, and this was mentioned earlier in the hour, in most places people have changed the way their team works in order to, so that not everyone is exposed all at the same time. We don't really get together as a group. We're in meetings on Zoom and that sort of thing, and typically on call you would have one attending and one fellow, and not getting together and not all being in the same place at the same time. And I think every place has gone to some variation on that theme to try to work more as a small team, a series of small teams. And then when you're not in the hospital, you're at home or wherever else you need to be that keeps you out of the exposure lane, so to speak.
Well, so that's a question for John. Is you work in the hospital and in the OBL? Do you work in the hospital and then the OBL, or do you work them both at the same time?
Different days, obviously. My days of the OBL, my days of the OBL, my days of the hospital, my days of the hospil. Same thing for my partner.
You're not segregating those teams then?
No, they're completely different staff, completely different, teams, completely different, performance metrics. Yeah.
But it's the same interventionalists, is what you're saying.
Same doctors. Yes.
Okay, all right. So we got about 10 minutes left. I mean, maybe you want to start summarizing things, Peter, about what are the messages coming out of this?
Well, I think there are a lot of things to consider, and I'll be interested to see what others think. But I'm really impressed with how thoughtful everybody is about what's happening in their situation. So we're taking these maybe some nationwide guidelines, let's say, and trying to apply them to our own situations. Obviously, this is a big deal. As John said, it's probably feels pretty threatening to have it. It feels threatening enough to be in the zone of everybody worried about it, ourselves, our staff, our patients. It's affected things so dramatically in terms of the hospital and how it functions, how it works. But I think at the end of the day, my takeaway is that we will get back. We will be back smarter. Our practices will be busy again with the right things, but we're going to actually take away a lot of good learnings from this. Some things we just talked about, about guidelines, about teams, about how to protect yourself, how to protect the patients, how to include the patients so that they understand, what we're doing to mitigate risk on their behalf, so that they feel comfortable, since we really need to treat the whole patient. So just some thoughts there. I don't know, John, did you have anything to add?
I think that in as much as we can do some telemedicine or, some sort of outside of the hospital communication with patients, that's going to become part of our practice now more routinely, especially for those patients who are smart enough to be engaged. This whole process of coming on a regular basis has for many years stressed the system and stressed the patients. And I think we're going to definitely utilize what we learned here and the platforms we now have to do more telemedicine and keep people out of the hospital.
So, John,
that's one way that I think we will come out of this a bit smarter in how to use our resources. And if you think of the standard vascular practice, a good chunk of it is that surveillance process of just making sure that what you did before is still functioning well and that the patient is well managed. And to the extent that we can have that done in a different way that's less labor intensive, that makes a huge amount of sense. I don't know, Drew, what do you think?
So I think a couple of take homes here is it's been great to hear John's experience as well. I think this has actually been some opportunities, I think, to be able to work cohesively as a team. And I think we've been at a benefit of having a great administration and working tightly. We're physicians and the administration working together with a complex team. And I think this is really showing great teamwork. Having a COVID command center at your hospital and working with people that you don't normally come across, I think is important. So I think in addition, the advent, telemedicine's been around for a long time, but I think, this has kind of forced our hand into using it. And, for those of us in Atlanta and major cities, people don't like driving in these cities. Even though right now it's very easy to drive in the city, I think we're going to see a lot more use of it for patients that are more remote. And so I think it's been a great opportunity with this. I think out of crisis comes some opportunity, but also some ingenuity. So I think we're seeing all of that across the board, and it's been incredible to watch.
Yeah, great points. Palma, what do you think? Any good takeaways?
I've noticed over the last several weeks, I think that a lot of people have come together. We're trying to stand strong together. I think societies have had challenges with meetings canceled, and we're all trying to evolve how we're going to do things. The female vascular surgeons have set up a lot more different mechanisms of media to, help each other. And a lot of people feel very isolated and distanced. And I think things are going to come out of that are going to be very helpful for everybody.
Yeah, good points. Good points. Yeah, Michael, what can you tell us about getting back to normal there in Germany?
Yeah, it just started, so we are on a very slowly way, step for step. But I can absolutely agree what was said here. Team spirit, yeah. I never saw such a great team spirit like in these times. Yeah, I'm so proud of my team. Actually, they did give every day the best. Yeah, and fighting for these patients, fighting till the night, yeah, and most of them are really, really down. But a lot of them already told me this shutdown, even that we have a catastrophe, this shutdown was really a very good thing. Yeah, we really calmed down. Tough battles stopped. Yeah, we worked, as you said, very close together with administration, with governments. We did not fight. Yeah, we discussed and just tried to be as productive as possible. And this was so impressive.
That's a great point. Great point. Yeah. Alan, how about you?
Yeah, I think what decisions which normally would take months are happening in days. So I think there's going to be a new expectation in terms of how fast we can actually make things actually happen. For example, the telemedicine thing, we've had telemedicine platforms set up here probably for well over a year. We went from having 40 visits a day to over 3,000 visits a day in a week. And just because all of a sudden the docs kind of bought into the idea. I think the other thing there was a lot of resistance to deployment of virtual ICU. Now it seems like the greatest thing because we don't have to go into these rooms. It's really interesting to hear how Michael's turning the corner. I guess one of what we don't really have a sense of is how long that transition back is going to be. And I'm a little pessimistic. I think it's going to take the rest of the year to get kind of close to back to normal. I'm a little surprised they're not doing more testing of patients who are coming into the outpatient centers, in Germany, because I kind of imagine that that's going to be the way back, is you're going to have to be able to show you're COVID negative in order to be able to go in the restaurant, for example, let alone coming into an operating room. And I do think you're going to see switches from the hospitals into either remote hospitals out in the periphery or into OBLs, because I'm not entirely sure that it's going to go back to business as usual in these big tertiary care centers. I think the one other group that we've not really talked about is our residents. Our residents have done a phenomenal job, and we're obviously very concerned about exposing them, and we're real concerned about their training, and they're really concerned about their training. There's this huge gap. If you take a 2-year vascular fellowship and you eliminate 3 to 4 months out of it, that's a big deal. And so that's a lot of lower extremity interventions that they have missed out on. And we'd be remiss if I didn't say I take my hat off to the people working in those COVID ICUs. I mean, those are very, very difficult circumstances to be working in. And I really want to applaud the ICU nurses and the respiratory therapists and the proning teams who are really on the sharp end of this. And so with that, I think if there's any other final comments from the panel, now's the time. If not,
it's really showing the tremendous power of people working together, right?
Yeah, it really is. Yeah, it really is. It's the speed of the decision making and people working together, and we like to see that perpetuated a little bit more. So thank you all very much for taking time out and coming and spending it with us. Thank you, Palma. Thank you, Peter, for helping moderate this. We appreciate it. Hope this has brought some value. Thank you all.
Very good.
Stay safe.
Stay safe.